Very excited to be here with my Fort Cohen team. Danielle is here, our manager in the audience, and we have Dr. Patiesa, our attending, our nurses from Fort Cohen. So today's nursing grand rounds presentation is about epilepsy, our program that we really love, so dear to our hearts, and we're here to present and share that with you. Okay, so Dr. Patiesa is our Associate Director of EMU. We have Bianca Chabra, one of our nurses, Emily Trainer, one of our nurses, Colleen Germain, and Samantha Swikla. And part of the team, myself. The agenda for today, overview of the EMU program, case study presentation, care of EMU patients, nursing assessments, interventions, and safety alarms and concerns. And we're going to tackle experiences and challenges of our nurses caring for this type of special population and lessons learned and what happens in the future. So what are we about to do after all the lessons learned for these previous years that had happened? Okay, so overview of the EMU program. Dr. Patiesa will be presenting with us. Thank you, Dr. Patiesa, for your time and effort.
Thank you. So, as you heard, I'm Simona Protisa. The majority of you knows me. If you ever had patients with epilepsy, for sure they know me. I hope that for good. I am going to just say thank you for being invited here and thank you for our wonderful nurses on Fort Cohen, which, you know, sometimes is good and sometimes is bad to be that good because I keep bringing patients more and more complicated to the unit and they keep rising to the occasion. So this is how it's going to be. Now, let's discuss actually about epilepsy. Why do we dedicate a unit, not big enough, I think that it can be bigger, but why did we dedicate this unit specific to epilepsy? As you might know, epilepsy is actually a disturbance of electrical activity of the brain. In order to be diagnosed with epilepsy, you have to have 2 or more unprovoked seizures. And from time to time, we use seizures and epilepsy interchangeable just because epilepsy still has a very bad stigma, which I hope that following our presentation and education will address this, knowing that we can control it. Maybe we'll be able to decrease stigma. So seizure and epilepsy is not quite the same thing, but we use it together. And what does it mean non-provoked? Meaning that the patient doesn't have any electrolytes abnormalities, doesn't have any infection, inflammation, some brain tumor, anything like that. So if that's the first time when the patient has a seizure, we call it a seizure, then they don't qualify for diagnosis of epilepsy. And we are asking ourselves, so how frequent is this condition? And actually the prevalence, meaning the number of patients with epilepsy, is 0.7%, which actually, regarding to the American population, we do have between 2.5 and 3 million of Americans with epilepsy. If you look at the graph, you'll say, you know, it's not even that bad, but actually as a percentage, but when you look at the number, you realize that actually it is a big health condition. And actually in the lifetime prevalence is 3.8. And if you refer again to our population, you see that the number is quite high, and this number tends to increase the more we age. An aging brain is more prone to seizure, an aging brain more prone to stroke, to tumors, and that's sometimes this is the reason for which there is an increase in epilepsy prevalence. Now, out of this all patients with epilepsy, 1/3 will become intractable. What does it mean? We do have approximately 24 anti-seizure medication, and there are a lot of them still in research. Out of this whole population with epilepsy, 1/3 will become unresponsive to or resistant to medication. So that's why you might have seen patients on your floor who are on more than one anti-seizure medication, 3, 4, 5,
No.
even 6, which is not good. The more you increase the number of anti-seizure
Is this
medication,
live or
the
can you show
lower
what
the
I have?
somebody
I
will
can
have
turn it
to
down. There's a survey. I'm listening.
silence them.
I'm so sorry. Let's silence the one on Teams, right?
Yeah.
Sorry. Can someone help?
Okay.
Yeah.
It is okay now.
Is it? Okay.
So these patients, the patients that are resistant to multiple medication, develop so-called intractable epilepsy. And those are the patients that come to the emergency very frequent. They have a lot of comorbidities. And unfortunately, the risk of dying by SUDEP, sudden unexpected death in epilepsy, is higher. So that's the reason for which we put together all our efforts to try to control the seizures. Sometimes you can with medication, sometimes you have to change medication or just to consider epilepsy surgery. So those are the patients that I cannot advance. Let's see.
Yeah. There you go.
Okay, so what are the tools that we have in order to diagnose epilepsy? The most important tools is actually our brain. We have to look at the patient. We have to look what a patient does. But when a patient comes to the emergency, you hear a story that they were shaking, that they have generalized tonic-clonic seizure. Usually this is what you hear. The story is not quite accurate. It might be that whatever a bystander witnessed was the spread of the seizure, not the onset. So when a patient is admitted to EMU, and I'm going to tell you type of admissions that we have in EMU, but when a patient is admitted in EMU, we have to answer 3 basic questions, but very complicated questions. Does the patient have epilepsy? Does the patient have, what kind of epilepsy does the patient have? And where does the seizure start from? So one of the reasons for which some patients do not respond to medication is that sometimes they don't have epileptic seizures. So you have to make sure that you know what you are treating. You might have heard about the psychogenic non-epileptic seizures, which are non-epileptic events. They can resemble very much the epileptic seizures, but they are not. So obviously that if you give 2 or 3 anti-seizure medication to a patient that doesn't have epilepsy, they are not going to respond to medication. So for this reason, we have to use a tool. And the tool that we have is this here is the EEG recording. Now, this is a tool that also helps us to understand what kind of epilepsy a patient has. And basically, epilepsy is divided in 2 big groups, which are focal and generalized. And this classification is important because we have different medication and different surgical approaches for each of this group. There are other types of seizure that are not belonging to these big groups, but those are the big basic type of epilepsy that we do have. And then where do the seizures start from? It is important because if we consider any type of epilepsy surgery, we have to know exactly where the seizures start from. So this is our tool. This is the EEG. And you might see here in the right lower panel that those are the electrodes that are basically applied to the head with some glue, with some sealant. And the basic montage that you see here, it is called double banana just because the electrographic connection, as you see, resembles a banana shape. And this is the double banana 1020 or bipolar montage. Is the most used montage in epilepsy. Those are electrodes recording, as you see numbers here. The uneven numbers are the one recording from the left side, and the even numbers are the one recording from the right side. As you see, FP1, F3, those are electrodes that record from the frontal part of the brain, then the central part of the brain, and then you have here the temporal part. And we do look absolutely symmetrical in the left and in the right. So a patient, when they come to EMU, a patient is observed and monitored in a bed, we have a camera which is centered on patient, and camera reports the transmit images to the we have a PCA watcher. There is a big screen outside the EMU rooms in which these patients are monitored 24/7. The PCA watchers are the one looking for any possible abnormal activity, and they are the one alerting the nurses that there is a possible seizure activity for a patient. You might see that the bed has padding because you want to avoid injuries. You might see that the patient has an IV place because we do like to capture seizures, but we do not like prolonged seizures. And prolonged seizures have to be interrupted to decrease the risk of respiratory or cardiac distress or cardiac arrest. And this is the scalp EEG. This is the type of EEG that we use very frequent. Now, how do we know if somebody has a seizure? We do see this so-called wiggly lines. Actually, those are different type of frequency that we measure in between 1 second. So if we measure here in the occipital region, 1, 2, 3, 4, 5, 6, 7, this is part of the posterior dominant rhythm. This is exactly one feature of normality that we see on EEGs. Now, if there are some changes on the EEG, as you see here highlighted in pink, this is the left hemisphere. And if you look and if you compare the left side, especially the left temporal in this region, with the right one, you see that the frequency are a bit different. The waves are a bit higher than the one on the right side. And there is some evolution, meaning that it starts from a bit slower and then they keep evolving. This is a left-sided seizure. And once we know something like that, we can go ahead and see what are we going to do next. Now, this is an overview of how did we grow, over the years. Starting 2016 up to now, we see that we increase, we double our volume, and we have a dip obviously in 2020, but we did pick up quite nicely in 2021. And those are the number of admission that we have in EMU. And I'm sure that you ask yourself, so what's the difference if a patient is admitted in EMU versus a patient who's just getting an EEG, anywhere else in the hospital? And actually, there is a big difference. We have data that show, I'm not going to show it today, but we have data that show that the rate of readmissions at 30 days is lower for patients who have been discharged from EMU as compared with patients who have been discharged from other floors in the hospital. The data is not so clear. That's why we didn't present it as of yet, because the pathology can be quite complex. So what kind of admissions do we do in the epilepsy monitoring unit? We do have elective admissions, and we do have non-elective or emergency admission. This is a snapshot from the type of patient that we had in 1 month in EMU. And you might see and appreciate that actually we were quite, gender neutral, meaning we had admitted equal numbers of female and male. It doesn't happen so often, but it did happen in that month. So reasons for elective admission, those are admissions that are already prior authorized by the insurance. And we do admit patients in the unit to see, do they have epilepsy? This is exactly what we want to know. Event characterization, meaning, do you have epilepsy or you have something else? You might have syncope, you might have something else. Now, we did have like 64% in that month. That was the reason for elective admission. Some of the patients did have seizures. Some of the patients had seizures while on medication. At that time, we were also having autoimmune encephalitis exacerbation associated with seizures. And a lower number were related to patients that will have surgery, epilepsy surgery, patients that came for medication discontinuation. You know, if you don't, I will tell you now that in general, if you are seizure-free for 2 years, sometimes we do attempt medication discontinuation to see if you can be seizure-free and medication-free. How do you do this? It is better to have the admission for at least 48 hours in EMU to document that the EEG is normal during that admission, and then it is safer to slowly taper the medication. We had a patient with MELAS exacerbation, which is a mitochondrial disorder, and we have this interictal evaluation, meaning patient who, despite having being on a lot of medication, they still have some symptoms. And then in between seizures, you have to see, do you have any reason for that patient to have a seizure or not? And this is when we call it interictal evaluation. And I think that at this time, I also have to tell you that basically a seizure is divided in 3 parts. There is the pre-ictal, meaning before the seizure, whatever auras, whatever symptoms you have from the region of the brain that will cause a seizure. Then there's the ictal period itself when the patients have seizure, and then there is the post-ictal period in which patient usually is sleepy or confused, and this is something that will focus to see what kind of measures do you have to take depending on the stage where you are with your seizure. So, and then another reason for elective admission was pre-surgical evaluation and rapid medication change. What does it mean? Pre-surgical evaluation meaning that a patient comes in the hospital, we taper off the medication that he or she is on, 2, 3, 5, whatever number is there. We capture seizure, we need 3 seizures, and it sounds counterintuitive. You know, you have a patient who doesn't have seizure and you bring them in the hospital to have seizure, but we have to characterize the seizure to see exactly where do they start from in order to have a surgical plan. And then patients for rapid medication changes. Our anti-seizure medications have a lot of side effects. If a patient has a severe side effect, you cannot change this medication at home, or it is advisable not to change it at home. You bring them in the hospital, you stop the medication, and then you load them with different type of medication and you send them home. Now, what's the reason for non-elective admissions? Those are a big bulk of our admission to EMU. Those are the admissions from emergency. Usually when you have seizure exacerbation, then you have to look for what are the causes for seizure exacerbation. They are this type of new onset seizure. The first seizure, I told you that once you have the first time seizure, you do not qualify for a diagnosis of epilepsy. But usually this seizure, the first time seizure, is not the first seizure that the patient has. Usually that's the first convulsive seizure that the patient has. They might have had other seizures in the past. And if their EEGs are normal after the first seizure, meaning that the risk of having another seizure is more than 50%, they will need medication after the first seizure. And we did have the autoimmune evaluation at that time. And then we have this non-specific complaints that I'm sure that you are very well aware with. Altered mental status, if we have a suspicion that altered mental status was secondary to a seizure and maybe a patient went in non-convulsive status epilepticus, patients who have severe seizures because they have different type of infection, patients who came to the emergency because they have multiple events and we were not sure if they are seizure or not, patients who came in the emergency with a second seizure and they are not on medication, or they are on medication that do not control their seizure. We did have a social admit also, and we did have some post-surgical sequelae. And medication side effect that we did not bring electively, but rather came to the emergency, and those were admitted to EMU. One of the most frequent side effects, and please remember that Keppra is a medication, or levetiracetam is a medication that we use quite often. And one of the side effects is that it can make you irritable, depressed, or suicidal. So if you have this kind, if a patient has this kind of side effect, you have to bring them in the hospital and to stop the medication immediately because of the side effect. But you have to replace the medication with something else because otherwise the patient is going to have a seizure. Now, Well, how do we know? And this is what we are asked by the administration, and actually this is what we ask ourselves. How do we know that we are doing well what we are doing? So we do have structural measure, meaning that we do have our program is accredited, is following some guidelines that are nationally recognized, and we are level 4 epilepsy center, meaning we are the highest level of epilepsy center that it is possible, meaning that we have pre-surgical evaluation, we have surgery, we have neurostimulation. Our EEG technicians, our EEG lab is also accredited by ABRED, by the Society for EEG Technician Accreditation. Now, in the unit, and this is an ongoing process, and we started, very complex, and we strive to improve. We do have protocols. We do have protocols for prolonged seizures. We do have protocols for agitated patients. We have different type of protocols for safe medication reduction, and those are protocols that usually we do update them. And we recently we just approved, and it is approved over the whole system, the protocol for status epilepticus with newer anti-seizure medication. And then we have the epilepsy dashboard, where we do see the number of hospital stay, the delay in admission from the emergency till the patient comes to the floor. And the order utilization, we have order set that we also monitor. Now, we also measure outcomes. So why do we measure outcomes? Again, we want to see if we can improve and if we are doing whatever we are doing, and if we are doing it well. So surgery outcomes, we have patients who have epilepsy surgery, and those patients, every week when we have our surgical conference, we do present update on 6 months, 1 year, 2 years post epilepsy surgery to see, is the patient happy, is the patient seizure free, they still have seizures, maybe it was only a palliative procedure, not a curative procedure. We also look at quality measures and outcome measures. If we monitor somebody for maybe 7 or 10 days, and if they have the skin integrity is broken, meaning that we didn't take good care of the electrodes, so we do look at how long can you keep a patient on EEG without giving them a scalp break. We look at falls in EMU secondary to seizures, and also we look at if we had to transfer a patient to a higher level of care, meaning that we couldn't control the seizures with in our EMU, and because of over medication, the patient had to be transferred. And we also look at EMU length of stay and readmission at 30 days. Now, why is quality and outcome important? And I'm sure that whenever you look for a hospital or a division or a program, you want to see what's the impact, what kind of quality measure that program has. And then we really want to standardize the highest quality of care for the patient, not only for our center, but for all the epilepsy monitoring unit in the system. We have to make sure that our patients are safely monitored in the unit. We want to make sure that patients do not go into convulsive status epilepticus. We want to improve seizure control after completion of EMU, and also we want to maximize satisfaction of patients and referring physician. And now, actually,
Thank you, Dr. Protesa. That was very informational.
So for EMU, we have an overarching goal. Epilepsy patients shall be cared for in a safe and standardized manner. Here we have our depression screening tool. We use this tool for patients to help with the depression or other psychiatric comorbidities when they are admitted to EMU. By doing this assessment, it helps the team determine if the patient has depression, anxiety, or other mental health conditions that could be a trigger to an epileptic event. Patients with epilepsy have a higher chance of having depression. Patients who have depression or anxiety can experience psychogenic non-epileptic seizures. So how do we manage a patient that's having seizures? These are just some general guidelines. First of all, the room is always set up with suction, a non-rebreather, and the rails are padded for patient's protection. We also have the patient hooked up on the video EEG, and the patient is always on camera. If the patient is suspected to be having a seizure, the first thing is that the button is pressed. On 4 Cohen, we actually have a PCA that sits in front of a computer and can witness all the patients who are under EMU. If the PCA sees the patient seizing, she'll press the button and all the nurses who are ever called will go into the room. We make sure that the camera is not blocked or have anything in its view, and we always maintain the patient's privacy. During seizures, we note what movements are happening. Is there a patient biting their tongue or what extremities are being stiffened? Some other guidelines for managing seizures, we always assess the patient's safety. From the moment the seizure bell is pressed, the seizure is going to get timed. During the seizure, we make sure the patient's safety is maintained. We make sure all 3 side rails are up and we're assessing the patient's airway, breathing, and circulation. Heart rate and SpO2 are also being monitored. If oxygen falls below 95, the non-rebreather is placed, and if the patient bites their tongue, we will now put them on the side and suction them to make sure they don't choke on their saliva. During the seizures, we ask patient orientation questions and we reorient them until the seizure is over. We always stay with the patient until the seizure is over. During the seizure, the neuroresident is called to come assess the patient at bedside. All EMU patients have 2 rescue medications ordered for their seizures. Most of the orders are first line and second line of defense, and they have instructions in the order. Most orders are given is 2 milligrams of Ativan IV push for a GTC that lasts greater than 3 minutes. And the second line of defense is for status epilepticus patients that last longer than 5 minutes. If the patient has no IV access, IM midazolam 10 milligrams will be given.
So this is a patient algorithm, what they do immediately, 5 minutes and 15, 30 minutes. So immediately when a patient's having a seizure, we press the event button so the person monitoring the video EEG can go back to the time. We record the seizure. Once we hit the room, we ensure the patient's safety, the bed's locked in the lowest position, the side rails are padded, and 3 side rails are up. Someone does call the neurology resident up when the seizure event is happening. We monitor the heart rate and SpO2. We document them every 5 minutes. If the SpO2 is less than 95%, we do give we put them on the non-rebreather, and then we perform ictal testing if the patient is stable during their seizure. This is the post-ictal test. So we ask them to remember a certain color. We ask them if they could say the word house. We ask them to point to like the bathroom door. We'll ask them like what object this is. And we'll ask them like what they do with it. We'll see if they can like raise their arms or squeeze their hands. We ask them how they're feeling right now. And we ask them if they can describe what they see and what they're feeling. We do this post-ictal testing for patients who have focal seizures and not GTC seizures. We ask this before and then after the patient has a seizure. This is a patient algorithm for a patient who has a seizure about 5 minutes long. If the seizure is ended, we give support to the patient and we reorient them. If the seizure keeps going, the first rescue med is given after 3 minutes, which is most likely IV Ativan. If it's going on for 5 minutes, we give the second line of benzodiazepine or an IV anticonvulsion drug. The neurology resident will be at the bedside at this time, and they'll be notifying the epilepsy attending to see what further management we should do. This is the algorithm for 15 and 30 minutes. We still remain at the bedside. We give support to the patient. If the patient is not improving, another drug may be given, but we would have to have the doctor order that. And if it's still 15 and 30 minutes afterwards and the seizure is still maintaining, an ROT will be called to protect the patient's airway. And this is the post-ictal testing. So after the seizure, after the patient comes out of the seizure, we ask them, did they have a seizure? Like, what did they feel? Can they remember the color? I ask them to remember prior. Can they do the object? Can they raise and squeeze their hands? And we ask them how they feel. I had a patient once who was having a focal seizure, and he was able to look at the bathroom door and able to he was trying to lift his hands, but he wasn't able to speak. So when I did the post-ictal testing afterwards, he was like, I knew what you were saying to me. I just couldn't perform the task. So that helped the epilepsy attending determine what type of seizure the patient was having. And here's some staff challenges that we experience with epileptic patients.
So there are several challenges that we see as staff, challenges for us, but also challenges that we see the patients are facing. So the first one I'm going to talk about is the social determinant of health. For example, we see a lot of patients that come from low-income households or they might be homeless. Some of them might not have insurance to pay for the medications or access to the funds to pay for them. And a lot of seizure medications could be quite expensive. This creates a boundary of medication compliance and could result in readmission. So as nurses, patient education is very important when talking about medication compliance, and the patient should be educated on the importance of medication compliance and how just skipping even just a few doses puts the patient at risk for seizure activity. Additionally, case management should also be notified of these issues so they can help provide the patient with resources that help them get medications at a lower cost and are more accessible to them. A second challenge that we see with the EMU patients is that there is sometimes a psychiatric component to their seizures. So we may have to have the providers consult psychiatry to help navigate their admission and discharge planning. Patients that are having suicidal ideations or at risk of hurting themselves or hurting others may require a one-to-one observation while they're in the hospital, just to keep them and also the staff safe. Nursing staff should practice active listening and therapeutic communication with these types of patients. And staff should also be educating them on medication compliance, not only with their anti-epileptic medications, but also keeping up with their antipsychotic or antidepressant medications. Challenges as staff we see is a lot of post-ictal aggression, which is when after a seizure, a patient may become very aggressive. Not that they're meaning to, but it's just part of the seizure episode after the ictal phase. It is a somewhat common occurrence on our unit that staff members can be harmed when a patient is going through a post-ictal aggressive episode. Because we have to try to keep them in bed so they don't try to get up and hurt themselves. So sometimes it takes, 5 or 6 employees to try to hold the patient down. And the patient sometimes is spitting, is biting, is scratching, trying to get up out of bed because they are very agitated and confused. When something like this happens, providers may order medications such as Haldol to keep them calm and keep them safe and keep the staff safe as well. But there is also periods where giving a medication can interfere with seizure capture. So provider might not want to do that as the first line of trying to calm the patient down. One specific example was we had a 25-year-old male who was admitting to EMU for the intractable epilepsy. And they had a stereo EEG placed, which is placed in the OR, where the leads are placed directly into the brain to get a better idea of where the seizure activity is coming from for maybe future like planning for the operation. The patient had a grand mal seizure, was shaking. After the seizure, became very enraged and very aggressive, was trying to stand on the bed and throwing the equipment at the staff. This caused 3 staff members to end up in the ER with multiple injuries. But once under control, the patient was intubated at the bedside and was taken to get explanted emergently because it was not safe for the patient and also the staff. In this scenario, patient and staff safety are of top priority. It is important to have enough providers and staff at the bedside during these types of seizures in the event that the patient becomes very aggressive. In addition, patients that are known to have GTC seizures are not supposed to be on restraints, which also can pose a challenge to staff. This is because if the patient is in wrist restraints or a POSI, for example, and they start to have a full body shaking seizure, they could seriously injure themselves. So we try to stay away from those and just try to use staff members and also medication to keep the patient calm in the case of post-ictal aggression. Additionally, there's also post-ictal confusion in which the patient is very disoriented after the seizure. They're not really sure what's going on, where they are. They don't recognize any of the people around them. In these scenarios, staff ensures that the patient is safe and everything's okay, reminds them that they're in the hospital and everyone is just there to help them. It is very important that when a patient is experiencing post-ictal confusion, that the staff stays calm and is patient with the patient and supportive to them while they come out of the post-ictal phase. Nursing staff should continue to ask the patient orientation questions during this period and take note of how long the post-ictal confusion lasts.
Right. So, hi everyone, I'm Sam. I'm one of the nurses. So basically, what have you learned, but really what are we continuing to learn? So, as a level 4 comprehensive epilepsy center, we have focused our training on continuing education across all disciplines. Through communication and teaching, we're able to continue to learn while giving the best care. So I'm just going to go through some of the examples that we have implemented on our unit together with our EMU team that's, kind of keeping things in the loop for all disciplines. So the first thing, over the last few months, our epilepsy team has implemented a very informative bi-weekly EMU staff education series. This is led by our EMU attendings as well as fellows. Our very own Dr. Protiza has also led some of these meetings. So basically each meeting focuses on different education topics centered around the care of our EMU patients. The meeting is held at shift change, either on mornings or evenings, so that we can touch several shifts, and it's open to all staff. So you can, our staff can join through Teams or in person. The second continuing education point that I want to bring up. We have CMT training for our staff. So this is crisis management techniques. It's a class in person. We are required annually to attend both RNs and PCAs. So basically, a group of our staff is sent a few days out of a month, and it's an 8-hour course. And retired police officers teach this course, and they basically teach our staff de-escalation tactics, physical, like ways to de-escalate physically aggressive patients the proper way so that the staff is safe as well as the patients. So that's really cool. And actually, some of our own security staff here do lead these courses. So it's nice to see, see them out of their security role and they're teaching us. So it's cool. Another point I have, so both RNs and PCAs are required to complete a yearly education for our EMU. The education consists of iLearn certifications and our neuro skills fair that we do yearly, which has all different components of, brushing up on EMU skills, whether it's watching, what to look out for, identifying seizures, interventions, things of that nature. And let me see. So this education is updated and modified each year so that our staff is up to date on the latest research and education surrounding the care of our epilepsy patients. And next, our monthly EMU task force meeting. So this is a monthly meeting where our nurse manager, our epilepsy attendings, fellows, EMU coordinator, EEG director and techs, as well as members from logistics, meet in person to discuss things like patient care, patient satisfaction, bed logistics, and patient outcomes. Basically, it's like a problem and solution format, and it's open. So everyone basically can just, throw out their thoughts and things that we can improve on, things like that. So it's kind of touching all disciplines, and it's a monthly meeting so that everyone's kind of on the same page every month. And lastly, so we have a new certification that we just recently started to send our nurses and PCAs for. So the certification is called the Seizure and Epilepsy Certification. No, I'm sorry. Seizure and Epilepsy Healthcare Professional in a Comprehensive Epilepsy Center. It's a certification offered by the NAEC. And since we are a level 4 epilepsy center, we have the opportunity to send our nurses and PCAs for this certification. It is an online course which consists of 2 tracks, each to be completed by RNs or PCAs, and it's tailored to each. It's an 8-module course, and they take it, at their own pace. But at the end, they take a 50 to 70 question test. And upon passing, they get this certification, which is like really prestigious. And right now, currently, we're able to send 2 PCs and 2 nurses per year. It's like a really expensive certification, so we're working on sending them little by little. And yeah, we've already sent a few of our own staff, so we're really proud of that too. Our hope is to have 100% of our staff certified in the, near future. So basically, to sum it up, for Cone, along with our EMU team and providers, we're constantly looking towards improving the care of our EMU patients. We're constantly meeting as an interdisciplinary team and figuring out new ways to better the care we provide. We believe the biggest and most successful way to do this is by continuing education, which I believe we've been doing a pretty good job at that. So, okay. And I think Dr. Protiza